I'm going to introduce all three of our next speakers together because they're going to form a panel on environmental with the focus on mental health in the environment. And certainly we've been understanding that the environmental issues, whether it's altitude or air quality, affects our heart and our ovaries and our pregnancies, but we're going to be talking more about our mental health. So to start with, I'd like to introduce Emily DiBlasi. And Dr. DiBlasi is an early career researcher at the Department of Psychiatry and the Huntsman Mental Health Institute. Her research focuses on the genetic and environmental factors that contribute to complex neuropsychiatric human traits such as substance abuse disorders and suicidal behavior. She uses demographic, genealogical, and clinical and genetic data to identify risk factors about suicide and overdose deaths. And she's building a research program that will specifically focus on women-specific risk factors and outcomes. We're going to have each of our panel members are going to have a quick discussion on their own, and then we're going to open it up to questions. So would you like to start?
Thank you. So I'm going to be talking about suicide, and this is, of course, a difficult topic. So if you feel like you need to leave the room or step away, please feel free to do so. And here I'm just putting up a few effective resources, which will be available. So there is really no single cause of suicide. Suicide does not equal depression. And that's really one thing I'm going to drive home today in the next 5 minutes. So 1 in 4 people who die by suicide is a woman. And these women who die are really understudied because most people who die are men. So recent rates of suicide have really increased, especially for women, increased 44% since 1999. And currently in Utah, more women die of drug overdose than men, which is just happened in recent years. And so suicide is currently the 4th leading cause of mortality for women. So Utah actually has really unique resources for studying suicide. We currently have a really high suicide rate, and you can see in this map here, the dark blue are areas where suicide rates are really high, and most of the Intermountain West, the suicide rate is very high. We roughly have about 650 suicide deaths per year. 23% of those deaths are women, and about 60% of those women have experienced a perinatal period. So many of them were mothers. Because of a 25-year collaboration with the Office of the Medical Examiner, we currently have the largest population-based data resource and biobank on suicide death. And I'm just gonna give you a brief overview of the Utah Suicide Mortality Risk Study. So that's that big data resource and population resource. So we currently have comprehensive data that is de-identified on Utahns that died by suicide from 1999 to present day. And by comprehensive data, I mean identify any of the individuals. So we link all our records through the UPDB, and de-identified data is given to our research team. So one concept I'm just going to talk about today is the exposome. And so you can kind of think about the exposome kind of like you would think about a genome. So this is all of the environmental exposures that an individual experiences throughout their lifetime. And in our research group, we really think about how to understand these diverse exposures and how they interact with genetic factors to really influence preventable death outcomes. And so I'm just going to kind of go over the concepts we think about, particularly in the research group in relation to the exposome. And these are physical factors or environmental exposures. So Amanda Bakian is doing some really great work looking at how temperature and air pollution increase suicide risk. And another thing we're focusing on particularly are allergies. And then some of the other things we might think about when it comes to suicide death. And these are things like socioeconomic status, socio determinants of health, things like healthcare access and insurance. So everything here in bold is what we can look at with our data and when we are looking at with our data, but there's of course other considerations. We want to think about lifestyle, sleep, employment, substance use, diet, exercise, as well as psychiatric conditions, as well as trauma. And so in our group, we're really focusing on sexual trauma, child abuse, familial suicide risk, as well as pregnancy-related factors, which I'm really focusing on. And so when we think about the exposome, we think about how these exposures really interact with biological responses, and how do those biological responses then ultimately end up in chronic diseases. And so the last little bit, I've really been focusing on comorbidities within women that have died by suicide. And so I'm just going to really briefly highlight 2 of the studies that I have done. So I did a series of what's called phenotype-based phenome-wide association studies. And that is where I, in a really broad way, look at all the diagnostic characteristics of women who died by suicide in Utah controls. So I looked at over 1,700 Utah women that died by suicide and over 11,000 population-based controls. And I did 2 series of studies. One was where I compared 128 female-specific chronic conditions to the controls, and the other study is comparing over 1,500 general common chronic conditions that are not specific to women, but both men and women. And what I found was really there are female-specific risk factors that we should be considering when we look at suicide risk. And so some of the top findings are things like inflammatory pelvic diseases, cervical cancer, mental disorders during and after pregnancy, as well as endometriosis and dysmenorrhea are really elevated in our women's suicides compared to controls. And so there are lots of other things we can be looking at. However, what I did here was kind of like a really broad diagnostic comparison using ICD codes. And so there's a lot of chronic female conditions that are left out here. So a lot of my work is really focusing on defining this using the electronic health record and really looking at these characteristics more to see what else might be involved. And so with the other study looking at all the conditions, kind of here is the big picture we see in comorbidities in women that died by suicide. So all these conditions listed here are really elevated in female suicide deaths in Utah. And so I just talked about some of the female-specific chronic conditions, but there's lots of other things that you might see and like say, okay, that makes sense, maybe due to stress and trauma, but we rarely look at the big picture. And here's kind of looking at the holistic picture. What are the diagnostic profiles in these women? And so we see things like chronic pain, back pain, incontinence, IBS, of course, all the psychiatric conditions, lots of previous suicide attempts and overdoses, migraines, lots of headache syndromes, epilepsy, things like multiple sclerosis, sciatica, vertigo, lots of inflammation and fibromyalgia, as well as chronic effects of substance use disorders and alcohol use disorders, as well as heart disease and hypertension. So with that, we just want to look at kind of a more holistic view of these exposures and how that results in chronic conditions. And we're seeing a significant amount of multimorbidity. And this is important because 90% of people who die by suicide have had contact with a healthcare provider in the last year of their life. So we think there are a lot of opportunities for prevention. And with that, I just want to highlight some of the people that I work with in the study.
I'm going to ask you to hold your questions. We'll have a panel discussion on these. And we're next going to hear from Dr. Shami Kanekar, who is a research assistant professor in psychiatry at the University of Utah Medical School of Medicine and the Huntsman Mental Health Institute. And since 2012, Dr. Kanekar collaborated with Dr. Perry Renshaw to develop a novel sex-based translational model, animal model, to study the neurobiology of major depressive disorder and suicide at altitude. I hope she's going to get into that a little bit because it's a phenomenal finding. And her group is the first to show a detrimental impact of living at moderate altitude on mental health disorders. If you go back to that map where suicide occurs in the US. Dr. Kanekar, would you like to have 5 minutes and then we'll.
So I only included 2 slides because I thought that's what we were supposed to do, given the limited time. But I'm going to switch gears here and talk about animal studies based on demographic data that shows that, see, how do you do the, oops. And how did I lose that? Okay, got it. So these are some figures from demographic studies. The first over there, there it is. The first couple of studies looking at suicide rates across the US versus altitude were published in 2010, and one by Perry Renshaw's group in Psychiatry. And this is a really dramatic image of suicide rates across the US in relation to altitude across the US. And you can see the darker areas, the dark brown, are the highest altitude regions in the US. And that's exactly where the highest rates of suicide are noted. Studies found that, I'm sorry, I keep losing this, there it is. Rates of suicides increased from about 2,000 feet above sea level. And since that time, this pattern has been found to exist across the world. Now it's 9 different countries, which shows that suicide rates increase with altitude of residence, despite different sociocultural and economic risk factors. In addition, studies in 3 different countries showed that rates of major depression also increased with altitude. And as Emily mentioned, Utah is particularly at high risk for suicide. It's on and off has been noted as the state with the highest rates of suicide. And this is despite also having the highest rates of antidepressant use. And then men have higher rates of suicide versus women, but as Emily also mentioned, women's suicide rates are increasing by 50%, or have risen by 50% in the last decade, while men's suicides have risen by much lower numbers. Okay, there we go. So this is a really busy figure, but we established an animal model to study whether housing at moderate altitude might impact biomarkers of MDD and also suicide. So living at altitude is linked to chronic exposure to hypobaric hypoxia. So with the low pressure at altitude, the number of oxygen molecules in a certain volume is lower than it would be at sea level. So when you breathe in a lungful of air, you essentially get less oxygen in each breath than you do at sea level. So what we did was we housed rats, Sprague Dawley rats, at 3 different altitudes, sea level, and in all these graphs, sea level is the black bar, and altitude is either 4,500 feet, the red bar, or the blue bar is 10,000 feet. So when rats are housed at these 3 altitudes versus sea level, rats of both sexes exhibit elevated depressive symptoms in the forced swim test. Rats of both sexes exhibit anxiety symptoms in a battery of tests. And we also see biomarkers linked to both depression and anxiety. And shown here is rats exhibit elevated serum IL-6 or interleukin-6, which is a marker for postmortem for suicide deaths versus deaths by other causes. On top of these deficits that are seen in both sexes, females also show anhedonia, in the sucrose preference test. That is, they take less pleasure from the pleasurable stimulus of eating sugar when they're housed at altitude versus at sea level. Females also show panic-like symptoms in anxiety tests. And the big one over here is when rats at the 3 different altitudes are tested for methamphetamine preference. Females respond, show much higher preference for methamphetamine after housing at altitude, while males really do not change. And this is just when we provided them with 2 different doses of methamphetamine, and that the pattern does not change. So since another biomarker of MDD that rats at altitude exhibit is lower brain serotonin. And so we looked at efficacy of SSRIs, that is selective serotonin reuptake inhibitors, which form about 80% of prescribed antidepressants across the US. And SSRIs require a certain amount of serotonin to function. And we figured since serotonin levels are lower at altitude, we figured that these may not work as well. So when we housed rats at sea level, this is the black bar is controls, and then the first 4 are SSRIs, and this is our positive control, the blue bar, which is a tricyclic antidepressant, disipramine. So when we looked at animals housed at sea level, both sexes responded to all 4 SSRIs, as well as to the tricyclic antidepressant, disipramine. However, after housing at each of 2 moderate altitudes, 3 of 4 SSRIs failed to respond failed to show antidepressant-like effects. And note here that antidepressant effects are a lowering of immobility in the first swim test. So fluoxetine, the yellow bar, or Prozac, paroxetine or Paxil, the green bar, and escitalopram or Lexapro, the red bar. All 3 of these did not work in rats at altitude. However, sertraline, the turquoise bar, or Zoloft, continued to work in animals at altitude. And we think this is because sertraline is not only a serotonin reuptake inhibitor, but it also inhibits dopamine reuptake. And so we think its activity here is based on reuptake of dopamine. So this implies that since SSRIs form over 80% of prescribed antidepressants, if SSRIs do not work as well at altitude, it implies that treatment-resistant depression is higher at altitude. And we know that treatment-resistant depression is highly linked to suicide. So all of these factors that I'm showing you here are, as Emily mentioned, deficits that are linked, that are risk factors for suicide: depression, anhedonia, anxiety, cognitive dysfunction, and substance use disorder, as well as treatment-resistant depression. So I want to end with showing some demographic studies on substance use disorder with altitude. A study from about 2014 had shown that both methamphetamine misuse and cocaine misuse increase with altitude of residence. And more recently, we did a study looking at prescription opioid misuse and found that if you look at the whole population across the US, there's no relation seen to altitude of residence. And there's no relation seen in men, but if you look at women alone, there is a positive correlation between altitude of residence and elevated substance use. And this was, we also found that fatal overdose by prescription opioids increased with altitude in both sexes. And we think that's because opioids dampen breathing, and that in combination with hypoxia ends up being a toxic combination. So these data together indicate that there's a biological risk for suicide that might occur with chronic hypoxia exposure at altitude. And it's important to note that this pattern is not just seen in people living at altitude. Higher rates of suicide and major depression are also seen in people with chronic hypoxic disorders, such as COPD, asthma, cardiovascular diseases, versus healthy people, and also versus people with chronic diseases that are not linked to hypoxia. So basically, chronic hypoxia forms a biological risk for MDD and suicide. Thank you.
That's an enormous amount of research, animal research. So everybody take a deep breath. Everybody take a deep breath. And I'm going to go introduce Ann Kirchhoff, who is a tenured associate professor in pediatrics at the University of Utah School of Medicine and the Huntsman Cancer Institute. And she's a healthcare services researcher. In other words, she looks at the primary concerns evaluating patient outcomes related to healthcare access and cancer's-related effects. So thank you.
Great. All right. Thanks so much for having me. I'm going to keep this quick. Before I get started, I just wanted to acknowledge my research team because we wouldn't be able to do all of this work without their wonderful help. So if you want to learn more about what we do, our website's down there at the bottom. But basically, I just have this one slide to talk about my team's work around climate change and cancer outcomes. And so we became really interested in this area, and it was really sparked by one of my former team members, Judy O, who is an environmental epidemiologist. And we had been doing studies that looked at how cancer treatment can cause, unfortunately, pretty severe health problems in cancer survivors. And cardio and pulmonary health problems are very common. So you think about that, someone going through cancer treatment, having cardiovascular and pulmonary problems. Well, think about air pollution. Air pollution affects all systems of the body, but unfortunately, respiratory and cardiovascular problems are common. And so if you think about Utah, right, in the winter, we get inversions where we get high levels of particulate matter. During the summer, high levels of ozone, right? So all of these things are bad for the general population. But what does this mean for someone who's going through cancer treatment? And maybe is already at a high risk for developing these health problems. So our team utilizes the Utah Population Database to be able to look at questions around how air pollution and other environmental factors affects the health outcomes of cancer survivors. So I'll just walk us across some of our results and then talk a little bit about our next steps. So we have two questions that we've been exploring. One is, do cancer survivors respond to air pollution differently than the general public? And what survivors are at higher risk? And one of the novel things we can do here in Utah using the Utah Population Database is actually use people with a cancer history and compare them to people without a cancer history, because we can get information on them kind of throughout their lifetime. And so a lot of the studies that have been done around air pollution and cancer outcomes have really just been limited to cancer populations. So this is a big sort of innovation that we're able to do here. The other question we're interested in is, does air pollution have more severe effects on survivors who have had certain treatments? So we know certain chemotherapies, for example, like anthracyclines, can cause cardiovascular health problems. Not everyone gets these types of treatments, so are we able to dig into this a little bit more? So I'll just walk us down the middle. So we've been able to leverage the Utah Population Database for several studies. Originally, we focused more on pediatric, adolescent, and young adult cancer survivors. So that's kind of the results I have here in the middle. So I just want to highlight two publications we've done so far. One, we were able to look at survivors of childhood cancer and compare them to a population without cancer from Utah. And we found that those who had received chemotherapy were much more likely to be hospitalized for respiratory related health conditions compared to the individuals without cancer. We were also able to do some studies where we looked at not just pediatric, but adolescent and young adult survivors, and found that those that were exposed to higher levels of air pollution, so with these studies, we've been looking at PM 2.5, are more likely to have higher mortality, right? And so this is really worrisome. So we were able to look at sort of air pollution exposure over several years after diagnosis, so kind of chronic exposure, and this is associated with higher mortality. Another question we're interested in around who might be at higher risk is around socioeconomic factors. So if you look down here, this is from that same paper where we looked at mortality as our outcome, and we saw as increasing levels of PM 2.5 happened, that individuals who lived in lower socioeconomic status neighborhoods in Utah were at higher risk of mortality. So this all brings up some questions of thinking about how to dig into this a little bit more to really understand these risks. With these studies in the middle here, we were able to do some analyses to look at specific cancer groups. And one group that came out as having higher mortality were young women with breast cancer. And so with that in mind, we've now actually been able to spin this into some additional studies where we're trying to do a better job of getting more granular information on cancer treatment and other sort of factors that might play into that risk, such as socioeconomic status. So over here on the far right, our next steps are that we got a R01 recently to really dig into breast cancer more. We've been sort of limited in our ability to look at things like treatment using cancer registry data. And so with this new grant, we'll be able to pull in records from the University of Utah and Intermountain to hopefully get a better feel for the types of treatments patients are getting. But what we're really interested in doing with this grant is not only looking at chronic exposure prior to diagnosis, but do a better job of looking at sort of the exposure that patients are getting during treatment to understand their health outcomes. The other aspect we're adding to the study is to really understand more how climate change is affecting. So we're looking at air pollution in our earlier studies, but that's not the only thing that's going on, right? Wildfire smoke is becoming more common. Unfortunately, things such as extreme heat are more common, and there's studies in the general population showing that the synergistic effect of all of these together really increases mortality. And so this is what we'll be looking at in this new grant. Would love to hear if anyone's interested in collaborating. We'd like to move into other disease groups, and we're starting to think about interventions as well too. And so I think a lot of what has been talked about today in the session around, women and their sort of connection to the health system has really started us thinking about sort of the intersection of some of these factors we're seeing and sort of ideas that we might have for intervention work. So ideas that we're sort of playing around with are, women tend to be sort of the main medical decision makers in homes. We've done some qualitative work showing that there's sort of a low level of knowledge of air pollution and sort of the impact on cancer survivors. They tend to be sort of making those decisions. So could we work with them, for example, for a home where there's someone with a cancer history or going through cancer treatment to do things such as getting HEPA filters in the home or encouraging the family to invest in wearing masks, those types of things. So lots to come, and was really glad to get invited to be able to talk about it. So thanks.
There's a red button on the bottom. There's a red button on the bottom. I don't think this is working yet.
Oh, yes, it is. Okay. Well, I have one quick question. That's for you. We know that women in the home are more likely to be the cookers, people spend more time in front of the stove. And so around the world, women's risk for lung cancer has to do with their exposure in cooking. And we know that people, and I have polluted my own household with trying to make croutons on a stove. So what are we doing to help women who have cancer to try to keep their indoor air pollution?
Yeah. I mean, I will say this is a very sort of early days in our work. I think one thing we'd like to do with some of these bigger population level data analyses is to start pairing it with more primary data collection to really understand these types of health behaviors, so that when we're starting to think about interventions, we can really design them with sort of the range of behaviors and sort of considerations we need to have. So, I mean, I think it's a really interesting time, right? Like there's been a lot in the news and sort of politically around gas stoves and things like that. So I think it's actually a really sort of good time that people might be receptive to this type of intervention.
So how about questions? We have three experts from different domains talking about survivability related to environmental issues. Certainly, we have a whole lot of important work that's being done here in Utah on altitude, on suicide and overdoses in women, and of course in cancer survivors. Any questions? Yeah.
Can you hear me? Does that
A
work?
little louder.
All right, well, hopefully this little microphone works. My question is, based on the altitude and the effects that it may have on depression and suicide, is that taken into consideration? You can acclimate or acclimatize. Because I'm looking on the CDC website, like about how we acclimate to higher elevations and altitudes. We talked about weeks, months, year. And for those individuals born here in Utah, are they committing suicide shortly after living here? Is that the relationship, or? Because for the most part, the human body adapts.
Right, but okay, let's quickly repeat the question, and that is the rate of suicide in newcomers or old comers? Can I briefly
So,
get it down to the people who've acclimatized?
The demographic study doesn't really analyze that. Can you hear me with this?
Yeah.
But there's evidence from Dr. John West from UCSD, who's done altitude studies for his whole career. And he found that even though we do adapt, we don't fully adapt for the hypoxia at altitude, even as low as what we experience in Salt Lake City, which is pretty moderate. So the human brain doesn't adapt. Breathing wise, we breathe harder at altitude, but that doesn't take care of the oxygen deficit. And this is shown in clinical studies looking at healthy people in Salt Lake City versus either LA or the East Coast at sea level, where they show that residents in Salt Lake City have lower arterial blood oxygen levels than people in LA. And then when you look at brain energetics, people in Salt Lake have lower brain creatine levels, which is a bioenergetic molecule in their forebrain, versus people on the East Coast at sea level. So these of course don't account for have you just moved here, but it does take into account people that have not traveled out of that altitude for a year. But adaptation, it doesn't happen fully.
Okay, thank you. And a question in the far back?
Would it be worth to try and further elucidate that by taking those patients in San Diego or LA and using an altitude tent where like the athletes that are using hypoxic conditions at sea level that control for other variables?
Yep.
Can you repeat the question?
Yes. He asked whether you could take care of that by taking people at sea level into hypoxia chambers or hypoxia tents, like is done for athletes. Now, studies like that have been done with extremes of hypoxia. So there's a study that showed that cognitive function in healthy adults is severely reduced from prior to hypoxia exposure to after, and I think it was like 10% oxygen, which is what you would experience at Mount Everest, right? Versus here. But you do see cognitive deficits after maybe an hour of treatment, something like that. So they have shown that hypoxia in the acute phase at least can affect you. Now, it's not that, I haven't seen any long-term experiments done like that. Thanks.
There's a question, yeah. You may have to just.
So Emily, I really enjoyed your presentation and nice to meet you in person because I know we've conversed via Zoom, but I've done a lot of work in endometriosis and the debilitating pain associated with endometriosis. And I'm wondering if in the Utah Population Database to get at procedures and prescriptions, because one of the big, so if you excise or ablate the lesions, and this is actually, there was a documentary that was just done on kind of endometriosis and endometriosis pain. Have you thought or have you yet brought in therapeutic procedures or medications to see how that might mitigate the risk of suicide, which I think would be very informative?
Yeah, that's definitely our next step. So we do have access to all that data and we have that in hand. It's just looking at all that. It's a great idea. Yeah.
Okay, one more question. Dr. Barnard?
This is for Dr. DiBlasi. As I was looking at all those different medical or gynecologic issues and psychiatric issues, it seemed like the elephant in the corner was domestic violence and abuse. And do you have data to track that? It seems like that might be.
Yeah, so a lot of the data we have is more interactions with the medical record. And so we have a limited amount of data on the life circumstances of these individuals. And I agree that that might be the precipitating event that causes all these things. But I think the way we look at it is just more like, maybe it doesn't matter what the initial cause is. Like, let's just try to look at some actionable targets, something that we can do. But I mean, that's a really important piece of the picture. We don't have that in our data as fully.